Okay, hello everybody. Bismillah ar-Rahman ar-Rahim. Welcome to the last session in the cornea series. And as we say in Arabic, khitamuha misk. So the most beautiful lecture should be with our guest speaker, Mouhamed Al-Aqaba. Mouhamed Al-Aqaba is a consultant ophthalmologist working in the UK. He is a substantive consultant ophthalmologist and corneal surgeon at the Rotherham Hospital Foundation Trust in South Yorkshire. Actually, he is a very well renowned figure in the cornea, not only in the UK, but as well in the Middle East. And he is a researcher, so he published so far more than 35 research papers. And he was awarded by national and international societies about 9 prizes so far, including the Ruskell Medal in Ophthalmology in 2010 for his work on human corneal nerves. His landmark paper, Architecture and Distribution of Human Corneal Nerves, has been cited more than 200 times since its publication in 2010. So please join me. Welcome, Dr. Mouhamed Al-Aqaba, and thank you very much, Dr. Mouhamed, for accepting the invitation, and the stage is yours now.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, good evening, my colleagues. Many thanks, Prof. Mazen, for the opportunity to speak in this outstanding platform and for the nice introduction. Today, I'll be talking about the management of microbial keratitis. Now, to outline the lecture, what's covered in this lecture is the medical management of microbial keratitis and updates on clinical trials. I won't be covering the viral keratitis and surgical management of infectious keratitis. However, I would recommend anyone interested in the surgical management of infectious keratitis is to go through our recent paper entitled Surgical Management of Infectious Keratitis, published this year in the Journal of Ocular Surface. Now, corneal scarring is the single most important cause of avoidable blindness, and infectious keratitis is the 5th leading cause of blindness overall, and causing around 3.5% of all blind individuals up to 2015. And severe infections, as we know, might lead to perforation and require corneal transplantation and long-term visual rehabilitation. Now, it's very interesting to go through some incidence figures. So the incidence of microbial keratitis in the Western countries, for example, the USA, is around 27 per 100,000 population. In the UK, it's about 40 per 100,000. However, a contrasting situation is found in Asia, where the infectious keratitis is really a public health threat. These countries face difficulties in accessing healthcare, poor health indices, and high proportion of workers in farming and agriculture. So, for example, in India, we have almost 110 per 100,000, and in Nepal, almost 800. Up to half of these cases can be fungal keratitis. So you could imagine the overwhelming burden of this condition on the healthcare system. Now, in any battle, you can't defeat your enemies until you know who they are. So you have to know, in infectious keratitis, you have to know your bugs, and you have to know your drugs, and you have to know your thugs, and we will go through them. Now, despite all the advancement in diagnostic and therapeutics, the outcomes are really still far from ideal. And this is because of a variety of reasons. We have challenges in making the diagnosis. We have cases of mixed infections, problem of resistant strains, new surgical planes, promising but not highly specific therapeutic modalities, and also we have to deal with unavoidable scarring, and which require a long-term visual rehabilitation. Now, the bugs can be quite virulent, as in this case with Pseudomonas. You will see the infection can extend from white to white within 24 to 48 hours if not treated quickly. Another problem is the mixed infection, as in this case, you can see the culture showed both filamentous and yeast fungal elements, and treatment has to be tailored accordingly. Similarly, concomitant viral and fungal infections can be found, as in this case, and without targeting both infectious agents, condition can progress. Acanthamoeba keratitis is really a challenging infection, and one of the difficulties is the way it presents. So it can present in pseudodendrites, limbitis, subepithelial infiltrates, corneal abscess, and even melt and perforation. And if we don't diagnose these infections quite early, we will end up with really drastic outcomes. The other difficulties come from atypical keratitis, like in this case, infectious crystalline keratopathy, which is bacterial colonization in the absence of an immune response. As in post-graft patient, we see it in people on long-term steroid or those who use anesthetic for a long time, and also following chronic herpetic eye disease. And the treatment can be quite challenging and sometimes require surgical intervention. Other atypical keratitis, fortunately, they are quite rare, but when they happen, it's really represent a big challenge to treat. We could have atypical mycobacteria, which is most commonly encountered after LASIK, nocardia infection, commonly seen in Indian subcontinent, and they present in a wreath-like pattern. They normally respond to amikacin and newer generation of fluoroquinolones. We have the actinomyces. We do see these cases after ocular trauma, and also microsporidia, which is a small eukaryotic spore-forming intracellular parasites. And interestingly, they present as superficial punctate keratoconjunctivitis in immune-compromised patients, but they do present as stromal keratitis in immune-competent patients. So all these represent challenges when we face corneal infections. The other challenge is corneal melt and perforation, which can make the medical treatment quite difficult, and often in these cases require surgical measures like corneal gluing or emergency therapeutic penetrating keratoplasty. Now, the principles of management, after a thorough history taken and a clinical examination, microbiological investigations need to be performed to identify the causative organisms. These include gram stain, PCR, and culture. Now, if you have access to confocal microscopy and anterior segment OCT, that will be an advantage, and we will go through their use and limitations. Now, based on your examination and history taken, and also the results of microbiological testing, we use targeted antimicrobial therapy, and we will go through them as well. Now, you have to remember to treat any inflammation, and the question here, when to treat and in which condition you should treat. When you face with a severe corneal infection, you will face corneal melt and perforation, and it has been shown antiproteases like doxycycline are quite helpful in halting the progression of corneal melt. You have always to remember to check the eye pressure, especially in severe infections, and use the IOP lowering medications accordingly. And don't forget, especially when you're using fortified antibiotics, the signs and symptoms of toxicity and how to treat. Now, back to the history. So you have to ask about the contact lens wear, the type of contact lenses. Are they rigid? Are they soft? Are they daily extended wear contact lenses? The pattern of use. Does the patient sleep with the contact lenses in, take a shower with the contact lenses in? And all these possibilities or these factors can give you a clue that you might be dealing with acanthamoeba keratitis. Trauma and corneal foreign body can cause infection, all types of corneal infection. It can cause bacterial, fungal, acanthamoeba. Keratitis and ocular surface disease, often caused by gram-positive bacteria, like this patient with OCP. You have to ask about history of cold sores, because that would direct you toward the causative agent, and also in case of superadded infection. Now, this is a very important factor. So sometimes you will face people with recurrent keratitis or recurrent keratoconjunctivitis. And unless you check the lacrimal sac, you are missing the nasolacrimal duct obstruction. And hence it's imperative to examine the sac in any patient with keratitis. You just need to press on the lacrimal sac, make sure you don't get a regurgitation of mucopurulent discharge. Systematic examination of the eye often gives you some clues to the etiology and help you plan the management. So you have to go through the eyelids, eyelashes, the conjunctiva, you examine for papillae, follicles. Then you look at the limbus. Can you see any sign of limbitis? And sometimes to be able to see the limbitis, you need to put a drop of 2% fluorescein, and you could easily see the elevation or protrusion of the limbus in these cases, in addition to the congestion. And we see limbitis in acanthamoeba, but also we do see these cases in herpetic eye disease. You examine the corneal epithelium with and without fluorescein, and that would help you to differentiate between the appearance of pseudodendrites here in patients with acanthamoeba, and you could easily differentiate it from typical viral keratitis dendrite with the terminal bulbs. When you come to the examination of corneal stroma, you assess and document the size, the depth of epithelial defect, and infiltrate. Look for corneal thinning, and if in doubt, you check for a sidal test for any leak. You examine the corneal endothelium for capies, endothelial plaques, anterior chamber for hypopyon, and iris for any sort of iris defect, and for posterior synecdoche. Now, it's really important to remember to check the IOP. This is often missed in the context of corneal infection. We get busy with the treating corneal infection, looking at the corneal signs, and we have to measure the IOP in these cases regularly. So I have come across a few patients with keratitis. They responded very well to topical antibiotics, but the patient ended up with poor vision and poor visual field. And that is due to unrecognized high IOP as a result of the inflammation. And people or patients end up with a significant discupping. The other important factor when you examine patients with keratitis is to measure the corneal sensation. Even if you think this is bacterial keratitis or acanthamoeba or fungal keratitis. Because people with poor corneal sensation, the cornea is often associated with poor outcomes due to high incidence of neurotrophic ulcers, melt, and perforation. So it's important to document the pressure and corneal sensation in these cases. Now, the other important factor you see in patients with keratitis, especially those who have responded to treatment, to the initial treatment, and then eventually, after 5, 6, 7 days, they showed a relapse of symptoms of redness, soreness, and blurred vision. You have to think about drops toxicity. And the ocular surface toxicity is often related to the concentration, frequency, and duration of the administration of the drops. It happens most frequently with fortified antibiotics like cafaroxime or amikacin. And to elicit the sign, what you need to do is to lower the eyelid gently, pull it down, ask the patient to look up, and then you have to look at the intensity and the distribution of redness in the lower palpebral conjunctiva, as you could see here. And compare it with the upper half of the conjunctiva, as in this figure here. Now, you will see in drops toxicity, marked difference in the redness between the upper and lower halves. And this is attributed to the toxicity. Now, if you document this sign, we call it the up-down sign of drops toxicity, then the next step is you have to either stop the medication if you have any sort of a preservative-free alternative, or you lower the strength. If the patient has responded to treatment, you just reduce the frequency. And that you should see improvement in the symptoms and signs. Now, one important thing to remember, if you have a bedridden patient, it's likely that this sign, it won't be there. So this sign is all to do with the gravity, and the drops is pulled down by the gravity to sit in the lower fornix. With regard to the microbiological investigations, now in vivo confocal microscopy is the most accurate tool for diagnosing acanthamoeba and fungal keratitis compared to PCR and cultures. Now, PCR is more sensitive for acanthamoeba than fungal infections, and the culture remains the gold standard for bacterial keratitis. Now, if you have all these techniques, that would really be a quite good thing in your practice to optimize the management of microbial keratitis. Now, when do we do corneal scrapes? I normally do them if I have large infiltrate, if I have central infiltrate affecting the visual axis, if I have unusual presentation, or if the pathology is non-healing. Now, how do we perform it? You put a drop of anesthetic, but please try to avoid, if you have access to tetracaine, try to avoid it, because it's been shown that it has a bactericidal activity. So normally we avoid tetracaine. We use proximetacaine or oxypupricaine. Now, you do the scrape using a 21 gauge hypodermic needle, but before you do the scrape, you have to remove all the loose mucus and necrotic tissue. You debride it and remove it, and then you take samples from the margin and the base. The other important factor is your plates, agar plates. You have to warm them up to room temperature prior to putting the samples. And normally the samples should be put in a C-shaped pattern. And the C-shaped pattern, that would help the microbiologist to identify if the growth is due to the actual infection or contamination. So if the microbiologists see the growth of the bacteria along the C letter, then that goes with your sample and with the actual infection. But if they see some random kind of spots not on the C pattern, then that probably is a contamination. So you have to remember these small steps. Now, when do we do corneal biopsy? We do corneal biopsy in patients with progressive infections despite treatment. And the issue is here, up to 50% of the cultures in bacterial in infectious keratitis are negative. And this has been attributed to a variety of causes, like the depth of the infiltrate, the sampling error, the prior use of antibiotics, and also slow-growing organisms. So the technique I'm using, I mean, there are a variety of techniques, but I use a trephination technique. And this technique involves use either of dermatological trephine or microtrephine, about 2 to 3 millimeter. And the device is advanced in the selected biopsy site until the desired depth is reached. And typically we aim for the anterior stroma. At this point, the blade is used to perform lamellar dissection, and then we obtain a free excised tissue. Now, the trephination can allow precise control of the depth of the excision, and therefore minimizing the risk of perforation. But you have to remember, larger trephine can create a larger scar and potentially have a visually significant refractive change. Now, when I obtain the sample, I divide it into 2 halves. I send one half to microbiology, and the other half, I send it to histology. Now, in recent years, we have been lucky here in the UK. Many hospitals have got access to a microbiology lab, which is an independent. So the hospitals have to pay for that. And this lab is based in Coventry. We send the samples and for microbiological investigation, and you could see the comprehensive range of assays. The PCR samples are usually taken by a dry corneal swabs, and we leave them in a special containers, double containers, and we send them by post to the lab. And we could check for the what we call a 16S RNA, because that gene is found in all bacteria. The 18S RNA, that is found in all fungi. Now, the benefits of PCR in these circumstances, it's the speed, the sensitivity in comparison with the culture and staining, and the capacity to differentiate between bacterial, fungal, and acanthamoebal. In addition, you could send the PCR for slow-growing organisms like nocardia, or atypical microorganisms like mycobacteria. So this is quite helpful, especially when we have a very high negative rate with the culture results. And you could see the turnaround time is like between 2 to 5 days. Sometimes you get the results within 2 days or even within 24 hours. With regard to the role of in vivo confocal microscopy, so I started using confocal microscopy in 2008, and since then it has become an essential part of my diagnostic tools in microbial keratitis. Now, IVCM is diagnostic in acanthamoeba keratitis and fungal keratitis. It's not suitable for making the diagnosis in viral keratitis and bacterial keratitis, and this is to do with the axial resolution of the machine, which is up to 5 microns. The other thing you have to remember, these sort of examination techniques require experienced operator, and also examining patients with corneal infection, they're already in pain. It can be quite challenging. So you have to put anesthetic eye drops, and occasionally you might need to put a bandage contact lens and examine the eye over the bandage contact lens. But it's quite useful. And in the eye emergencies, sometimes I do them even before doing the scrapes and PCR. And if I see any sign of acanthamoeba or fungal keratitis, I start them patients immediately on the antimicrobials. Now, I'll show you some images from acanthamoeba keratitis on confocal microscopy. So what you see here, it's the epithelial double wall cyst, which is kind of pathognomonic for acanthamoeba keratitis, especially if you see quite a few of them, and also if you link this to the patient history and clinical examination. So you can see here, this is a double wall cyst. This is another one. You've got one here, one there. So this is quite cluster of cysts, which is typical of acanthamoeba. This is very diagnostic. What you could see again is the double wall cyst here in the epithelium, which is quite clear. And this is another example of the double wall cyst. This one here. It's very, very, very sort of clear to see and to diagnose. Now, the other thing you see in the epithelium, it's the epithelial trophozoites. So they have this irregular shape on a light microscopy. But if you see here, you've got one trophozoite here and one trophozoite here. But you have to go through a few images to see them. This is one here, one here. So, and you see trophozoites in the early stage when they present to you. You could even see the actual trophozoite emerging from the cyst here. You've got another one here, but I'll show you a better example here. So the trophozoite, as it's flourishing on the corneal epithelium, the cyst is converted to trophozoite in a process called excitation. Another example here. Now, in this trauma, the diagnosis can be quite challenging in acanthamoeba keratitis. You have to remember you see a lot of keratocytes, but also if you have infiltrate, you get a lot of light scattering. So what I do normally, I look at the patient under a slit lamp, and then I document the infiltrate location, and then I go and examine the area at the edge of the infiltrate, where there is less light reflectivity from the scars and the infection, and you could document or see the double wall cyst. Now, the other thing is, as I said, at the initial presentation, you can see a lot of trophozoites, but once you start the patient on treatment, the trophozoites are under attack by the antibiotic. So the microbe or the parasite converts itself to a cyst form, and the cyst form is a predominant form you see in treated patients. And this is very practical point, because if you examine the patient, eventually the same patient on treatment, and you try to see if there is any residual form of acanthamoeba, you won't see trophozoite. And the only subclinical feature of the residual infection is the cyst. And if you have the cyst on confocal microscopy and the patient is getting better, you can't stop the treatment. You have to finish at least 2 to 4 months, or until the confocal microscopy doesn't show any cyst in this trauma. Now, in fungal keratitis, it's much straightforward. So in filamentous like aspergillus or fusarium, you will see intrastromal bright interlocking filaments. And once you see this, you could start the patients immediately on the treatment. I mean, if you want, and you could do some scrapes for culture, but most of the time, these sort of pictures are really diagnostic of fungal keratitis. Now, the role of OCT in anterior segment OCT in microbial keratitis is the ability to accurately determine the depth and extent of corneal ulceration and the infiltrate and the haze depth. So it can help to monitor the severity and the progression of the infection. However, the OCT, anterior segment OCT, has no role in the diagnostic package of infectious keratitis. Now, we've gone through the investigations. Now I'm going to summarize the treatment protocol. Now, if you have a typical microbial keratitis, which is acute focal keratitis, solitary epithelial defects and infiltrate, then you are dealing most likely with bacterial keratitis. If the infiltrate is a small size, less than 1 millimeter, then no need to do PCR or scrape. If the infiltrate is larger than 1 millimeter, then you could do PCR, scrapes, or even IVCM, confocal microscopy. If it is not typical, you could see multiple round infiltrates. You are in doubt what you're dealing with. Is it acanthamoeba? Is it fungal keratitis? Then you could do PCR if the lesion is really small. Otherwise, you could do corneal scrape, PCR, and confocal microscopy. Now, once you done your test, then the empirical treatment we use is fluoroquinolones. I use levofloxacin, preservative-free, 0.5%, hourly, day and night for 2 days, then hourly daytime for 3 days, then 4 times a day for 1 week. Now, it's very hard job to do if you ask the patient to do hourly, day and night. In these sort of circumstances, especially if you have severe infection, I admit the patient. And we have dedicated nurse. They put the drops every hour for the patient. I give cyclopentylate 1%, preservative-free, again, 3 times a day for 3 to 5 days to relieve the ciliary spasm and improve the symptoms of photophobia. If I see large infiltrates, maybe 2 millimeter, 2.5, or the infiltrate affecting the visual axis or hypopion, and the patient is contact lens user, then I normally use fortified dual antibiotic therapy. And the regimen I use is caparoxin 5% and amikacin 2.5%. So these are examples of the bacterial keratitis. So the image on the left is non-site threatening. And I normally use fluoroquinolone monotherapy, while the one on the right, it's quite central, quite large, deep, and you could see the corneal haziness, the severity of the infection is there. I would normally give them fortified antibiotics. Now, if you are faced with atypical infection and you suspect this acanthamoeba because you've got multiple epithelial and subepithelial infiltrates, you've got perineural infiltrates, you've got granular appearance of the epithelium and the anterior stroma, or if you've got the pseudodendrite pattern. And here I want to just highlight an important practical point. Do not diagnose herpetic keratitis or epithelial keratitis in contact lens user with epithelial dendrite until you rule out acanthamoeba. Now, if you have suspicion about acanthamoeba, what I do normally, if I have access to the confocal microscopy, I'll do it first before the corneal scrape and the PCR. If the IVCM is suggestive of acanthamoeba, I'll start the treatment. If the IVCM is not suggestive, I'll treat the patient as bacterial keratitis and I'll see them in 48 hours. The treatment of acanthamoeba keratitis, again, 1 hourly, day and night for 48 hours, then hourly, daytime only until review. And then we taper accordingly. The first line of treatment we use is PHMB, 0.06%, monotherapy. The second line is a chlorhexidine, 0.02%, plus gatiproline, which is 0.1%. And the third line is a higher concentration of chlorhexidine, 0.2%, if neither of the above available. If you suspect fungal keratitis and you have signs like satellite or feathery infiltrates, history of trauma with a vegetative foreign body or raised epithelial profile or infiltrate, if you see pigment in the infiltrate, if you see large endothelial plaque with pigments, then all these signs suggest that you're dealing with fungal keratitis. Again, the management is I'll do confocal microscopy prior to corneal scrape and PCR. Now, if the IVCM suggestive of fungal keratitis, I'll treat them as fungal keratitis. If no sign, then I'll treat as bacterial keratitis. I'll see them in 2 days and plan accordingly. So the treatment of fungal keratitis, again, hourly medication, day and night for 48 hours, then hourly, daytime only until review or you see a response. The first line of treatment is natamycin, eye drops 5%. If you are dealing with yeasts, if you have it on the corneal scrape or the culture or PCR, then I'll give the patient amphotericin 0.15%, or recently we've been using more and more voriconazole 1%. Now, if the infection is severe, I'll add chlorhexidine 0.2%, because chlorhexidine is a biocidal, and it is actually fungicidal as well, compared to other antifungals, which are fungostatic. So if you're dealing with a severe one, you could always add chlorhexidine 0.2%, bearing in mind the toxicity because it's quite strong medication. If you are faced with AC involvement, like hypopyon or scleral involvement, we give them oral voriconazole, 400 milligrams twice daily. And we have to monitor, we have to have a baseline liver function, and we have to monitor the liver function every few days. Now, Dr. Mazen, are we taking any question or shall I continue?
No, go on, please. Go on.
Yeah, so you treated the patient, you see the patient in the follow-up. So what do you look for in these cases? The first thing the patient would tell you, and that is very good sign, the patient would tell you, doctor, I feel much better. I feel better. although the vision maybe hasn't improved significantly, or the infiltrate size hasn't shrunk by significant size, but if they tell you that their symptoms are better and the vision may be a bit clearer, this is really the first and very good sign that your antibiotics are working. Now, the second important thing is the decreased size of infiltrate. So you have to document the size on a presentation and keep measuring the size of the infiltrate as you see the patient in the follow-up clinic. Also, if you see around the infiltrate, you could see a stromal cellularity. And if you see the density of stromal cellularity is decreasing, that means the patient is responding. The level of the hypopyon also can be a sign that things are improving. Now, the epithelial defect, you have to be very careful when you interpret the epithelial defect size, because if you use fortified antibiotics, the patients are actually responding. The infiltrate size is getting smaller, but you might see that the epithelial defect is getting bigger. You shouldn't change the medication. You could decrease the medication or add the lubricating eye drops. This is mainly due to the epithelial defects. The increase in size is not due to the worsening infection. It is actually due to drops toxicity, because the fortified antibiotics are really, really epitheliotoxic. You see in this example, after a few days, this is on a presentation, after a few days, you could see the infiltrate size has shrunk, but the epithelial defect stays the same or maybe slightly larger. You shouldn't be worried about that. You just need to maybe reduce the number. If it is hourly, I reduce it to every 2 hours. If it's every 2 hours, I reduce it every 3 hours, the eye drops, and I'll add lubricating eye drops. The other good sign of improvement is the formation of stromal haze and scarring, and it starts from the edges, and that is a good sign. Now, occasionally we might do intrastromal injections. In bacterial keratitis, we do them if the infiltrate is quite deep. I normally give 0.4 milligram and 0.0 ml amikacin. In fungal keratitis, if you are faced with deep infiltrates, you could give 50 microgram in 0.1 ml voriconazole. Now, the way we inject these is at the junction of the infiltrate and the healthy cornea tissue. And it's interesting that some papers, they've shown that with this method, you've got 80% success rate. Now, still there is a question about the number of treatments. People can give them every day. I could give them every day until I see a response. Some other they give every 12 hours. The other thing is with voriconazole, sometimes we give them subconjunctival every 12 hours in patients with severe fungal keratitis or keratoscleritis. And also you have to remember this, if you have a patient with limb disease, like fingers disease, like rheumatoid arthritis, you just can't give them the drops and tell them to use the drops, because practically they can't use the drops and they will miss a lot. And in these infections, it's crucial to use the drops frequently. So I normally give them subconjunctival because that would maintain the concentration of voriconazole around the cornea. Now, what if your signs and symptoms have not improved? You have to stop all the treatment, see the patient 24 hours, and arrange either for rescrape or you might do corneal biopsy. Now, what are the reasons of worsening of the infection after the initial improvement? You have to remember or consider the mixed infection. You might be dealing with bacterial plus viral, bacterial plus fungal, any combination. So you have to always consider these possibilities. The other thing is, ask yourself, are you using the right antibiotic? Is it compatible or is it indicated in the sensitivity section of your microbiology results. So you have to cross-check. And as I mentioned earlier, you have to remember drops toxicity. Not all worsening of the symptoms that mean worsening of the infection, but it might be the drops that you are using are causing the epithelial toxicity, the redness, and the treatment is really easily to reduce the frequency or change them to preservative-free alternatives and add some lubricating eye drops. The other practical point, when you use fortified antibiotics, normally they come with a label. Like, for example, cefuroxime, it's valid for 7 days from the time you open the vial. If the patient uses it longer than that, for a few weeks and months, that can get contaminated. They could get a secondary infection. So it's important to tell the patient, like, when you open this, you have to discard it in a week. I think for some of the fortified anti-acanthamoebal medications, the PHMB, it lasts for 2 weeks. So you have to remember these sort of factors. Now, I'll go through some landmark and some recent clinical trial in corneal infection and remind you how important these clinical trials in decision-making on a practical level. So in bacterial keratitis, I have come across 3 clinical trials comparing topical fluoroquinolones to the fortified antibiotics and looking at the outcomes. And actually, you see the result, the outcomes, there is no improvement in the outcomes with using fortified antibiotics. So they both are comparable. However, having said that, I still use fortified antibiotics due to fluoroquinolones resistance in my area. So you have also to have your sort of a clinical judgment on when to use them and not take them or take the results with a pinch of salt. What else might improve the outcome in bacterial keratitis is the steroid use. When do we use it? So these questions have been answered by the SCUT trial, which is the steroid for corneal ulcer trial. This is a randomized, double-masked, placebo-controlled trial to determine if there is any benefit in using topical steroid. They've recruited all the culture-positive bacterial ulcers, and they treated them within 48 hours with a steroid. 48 hours after starting the antibiotics. And the primary outcome was the best corrected visual acuity, 3 months, and the safety. And interestingly, what you could see here, there is no difference between the placebo and the steroid groups in terms of the vision, the infiltrate and the scar size, time to reepithelialization, and corneal perforation. However, there's something we need to highlight in this study. That doesn't mean the steroids are not important. In fact, they are really important. But this is a large study, almost 500 patients. And a significant proportion of these patients, they were treated by outside ophthalmologists or a clinician for a few weeks. So when they enrolled in the study and given steroids, probably they have been, with continuous inflammation and infection for some time. If we take, by doing the subgroup analysis and take all the patients who are actually treated early, which is 300 patients, so basically they had, from the time we made the diagnosis and the smear positive, 2 days after that, we started them on topical steroid. You will see in severe ulcers, they've got 2.7 line of improvement, which is quite significant. And also in moderate ulcer, you could see improvement almost 1 line. So in severe cases, if you start the treatment after you, if you start the steroid 2 days or a few days after you start the antibiotic, and obviously you document the response and you make sure you're not dealing with acanthamoeba infection, fungal keratitis, or nocardia. You have to remember nocardia is a bacterial, slow-growing organism. However, it is contraindicated to use steroid in these cases because the infection could linger around for some time and eventually you will end up with severe damage to the cornea. So the message is that if you're dealing with severe ulcer, after a few days of using topical antibiotic and you documented some response, you could start the steroid, topical steroid, and you will see a significant improvement in vision. Now, the other question is, which has been answered by the 2 clinical trials, is the role of corneal cross-linking in infectious keratitis. Now, these 2 studies, they didn't show any sort of significance of cross-linking in shortening the time to corneal healing. However, what they've shown both the studies that there is a reduced incidence of corneal perforation. And the recommendation is to use cross-linking as an adjuvant therapy in the management of severe infectious keratitis with corneal melt, because that would reduce the risk of corneal perforation. Now, we have SCUT-2 trial, which is a subsequent trial for the steroid use, but they added corneal cross-linking as well. This is a very interesting study. I think in September this year, they finished the recruitment and we're still waiting the results. Hopefully we can get the result next year. So what they've done in this study, they've done any smear positive bacterial keratitis, they divided them into 3 arms. The first arm, they were given moxifloxacin, then topical placebo and sham cross-linking. The second group, they were given moxifloxacin. They started them on steroid drops within 24 hours, plus sham cross-linking. The third group, they had all 3. They had moxifloxacin, they had topical steroid within 24 hours, and they have cross-linking within 48 hours. And what they are looking for, the outcome is 6 months visual acuity. Now, the reason we use cross-linking in bacterial keratitis, or the concept behind it, is that in many countries, we are facing resistant strains of bacteria and some other microbes. So with the cross-linking, we aim to tackle the infection and at the same time tackle the inflammation. And hopefully this trial will answer some of these important questions. Now, the trials in fungal keratitis, we have 2 landmark trials. We have the mycotic ulcer treatment trial 1. So basically this trial is a randomized controlled trial to compare natamycin 5% versus voriconazole 1% eye drops in the treatment of filamentous fungal keratitis. And what they found is that natamycin treatment was associated with significantly better clinical and microbiological outcomes than voriconazole treatment. So the practical advice here, voriconazole shouldn't be used as monotherapy in filamentous keratitis. And as a result of this trial also, there were sort of subsets of results being published separately. So they also checked the vision-related quality of life in terms of mobility, activity limitation, psychosocial impact, and visual function. And between these 2 groups, the people treated filamentous keratitis treated with natamycin or voriconazole, what they found is these measures are improved in natamycin patients compared with voriconazole. Then they try to answer the question whether if we repeat the culture in fungal keratitis, can it give us a clue to the prognosis? So what they've done among patients who tested positive and at the enrollment, they did another culture at 6 days post-treatment. And what they found is those who tested positive at day 6, they have significantly worse vision, larger scar size, and more likely to perforate and require therapeutic keratoplasty. And they also showed a slower healing. And the suggestion is that early microbiological cure on culture is a predictor of a clinical response to treatment. So if you have a facility to do that, that would give you a good clue on planning the management. The other group, they've tried to do a sort of a prediction model to try to see if there are any factors and a scoring system that could help to differentiate between severe fungal keratitis and severe bacterial keratitis. And they ended up with 7 predictors of fungal keratitis. If you have agricultural occupation, if you have a history of trauma, if you have longer duration since the onset, if the infiltrate is deeper within this trauma, if you have satellite lesions, endothelial plaque, and stromal melting, they are strongly suggestive of fungal infection. Now, the second trial, the mycotic ulcer treatment trial 2, so they tried to answer the question whether if we add oral voriconazole to the patients, to fungal keratitis patients who are actually as well treated with the topical medication, to see if there is additional benefits. And they found no benefit to adding oral voriconazole to topical antifungal agents in the treatment of severe filamentous keratitis. However, these are just corneal involvement. So if you get scleral involvement, if you get anterior chamber involvement, this is a different story. The use of oral voriconazole has been recommended in these cases. Now, the other clinical trial, they try to see what are the predictors of corneal perforation or need for therapeutic keratoplasty in severe fungal keratitis. And this is actually a sub-analysis of the mycotic ulcer treatment 2. What they found is, if in fungal keratitis, if you have a hypopyon, if you have very large infiltrate size, or if the infiltrates involving the posterior third of the corneal stroma, then this is a significant predictor of corneal perforation and requiring therapeutic keratoplasty. Other factors are insignificant, like age, sex, duration of symptoms, the visual acuity, the culture positivity, or the type of fungal organisms. Can we use cross-linking in fungal keratitis? As I mentioned earlier, in bacterial keratitis, it's useful in severe, where it showed to reduce the corneal melt and the incidence of corneal perforation. The story here is different. There is no benefit of adjuvant cross-linking in the primary treatment of moderate filamentous corneal ulcers, and in fact, it might result in decreased visual acuity. Now, this is the last bit. I'm going to discuss a few clinical trials regarding acanthamoeba keratitis. This is actually not a clinical trial, but it's meta-analysis. And I just wanted to highlight to you how important is confocal microscopy in both acanthamoeba and fungal keratitis. In this systematic review, what they've shown is confocal microscopy can be 94 sensitive and 87% specific in acanthamoeba. It can be 88 sensitive and 85 specific in fungal keratitis. Therefore, confocal microscopy is really, really useful in these two infections. Now, PHMB are still used widely in treatment of acanthamoeba keratitis, but until 2022, it's not licensed. There is no formal safety assessment. In this clinical trial, they've done the safety assessment in healthy adult volunteers. And the message is the PHMB 0.02% is safe. And higher PHMB concentration, which we are using now as monotherapy, showed acceptable level of tolerance and toxicity in acanthamoeba keratitis patients. Now, the voriconazole have been used in fungal keratitis. Is it useful in acanthamoeba keratitis? This small clinical or pilot clinical trial, they've shown that topical voriconazole as a monotherapy in acanthamoeba keratitis treatment is effective and comparable to PHMB therapy. Now, the issue is with this trial, out of the 23 patients recruited, only 18 patients completed the treatment. So the sample size is small. We need larger sample size and larger study to reach a conclusive evidence. So in summary, that microbial keratitis is a major public health burden. We always have to follow a systematic approach in history and examination. We have things have improved in terms of the diagnostic techniques, but still we are, I think, behind with some antimicrobials, specific antimicrobials for acanthamoeba and fungal keratitis. Corneal cross-linking have been shown some results in severe bacterial keratitis to reduce corneal perforation and melt. And we are welcoming any more clinical trials in this field. Thank you very much, everyone, for listening, and I'm happy to answer any question.
Thank you very much, Dr. Mohammed. Actually, it is an excellent presentation and an excellent lesson of up-to-date information, comprehensive overview of the corneal infections. Really, it is a great reference, actually, and I'm proud to have it as a video on my YouTube channel as a reference for everybody. Now we open the discussion and the questions. There is a question. Autologous serum, is it useful for preventing corneal perforation in infectious cases, and when should it be used?
No, we don't use it in bacterial or infectious keratitis. Normally, it's used when the infection is clear and you have evidence of neurotrophic elements. So most of the time, we use it in neurotrophic keratitis, like people with chemical or ocular burns, people who have neurological intervention resulted in corneal anesthesia. But we have to be very careful in using it in infectious keratitis.
Perfect. How about doxycycline for corneal melting? What is the dose and for how long?
So normally I use 100 milligrams once daily for a week, and then I reduce it to 50 milligrams. I could use it even for a few months. Okay, I don't need normally, but it's very safe. You could use it. However, you have to warn the patient. They have to drink a lot of water when they use the doxycycline. In bright sunlight, they need to wear sunglasses because while they are on the treatment, they might have photosensitivity.
Interesting. After performing the corneal biopsy, do you recommend using a therapeutic contact lens to cover the corneal defect?
So it's very, very good question. Now, normally we don't prefer to put a bandage contact lens on infected cornea, basically because you won't reach the therapeutic level of the eye drops. So most of the patients with the severe corneal infection that require corneal biopsy, they're already in that sort of discomfort from the infection. Put in the bandage lens, just because you've done the biopsy, it doesn't mean that the pain will be more severe. Or so I don't normally put a bandage contact lens.
Mhm. That's fantastic. I think these are the questions. No more questions. We can wait maybe 2 or 3 minutes if nobody. Yeah.
I mean, the question to the audience also, if they do they sometimes have difficulty accessing some of the anti-acanthamoeba or antifungal eye drops?
Yes, I can answer yes.
It is.
Because in some countries there is such medications are very much restricted. So um, maybe we have to bring them with somebody coming from another country while they are coming, for example. So yeah, we suffer. We suffer. In some countries, we suffer. Yes.
This is quite interesting because, you know, in Indian subcontinent or Asia, and also in Egypt and Middle East, a significant proportion of people with the infections, fungal. So I think it's a good thing to invest, or one of the pharmaceutical companies to invest in this and try to get a license for some,
Yeah.
because at the moment it's only netamycin FDA approved.
Yeah.
The rest are not approved yet, like voriconazole or amphotericin. They're just made locally.
Yeah. Off label.
I could see that which corticosteroid is preferable. This is a very good question. Now, I use the weakest we have here, which is the Pratzol minims, which is prednisolone 0.5%. And the reason for that is it has very good corneal penetration, but it has a minimum effect on the IOP. So, and normally I use preservative-free. So the advice is any drops you use in corneal infection, if you have access to preservative-free eye drops, use them.
Mhm. When to stop the antibiotics and what is the protocol?
So there is, to be honest, there isn't any protocol for this. So it depends on the response. Most of the people with like small solitary lesion, in a matter of 2 or 3 weeks time, once you have cleared the infection and you see the haze around that same area of the infiltrate, you could stop the medication. Now, this is also a very interesting question, but what I have seen is some people, when they reach to, so my protocol is hourly day and night for 2 days, then hourly daytime, and then I reduce it gradually to maybe every 3 days, I reduce it to 2 hourly, 3 hourly, 4 hour. When I reach 4 times a day, I continue 4 times a day. Now, for bacterial keratitis, as I say, in a matter of 3 or 4 weeks time, things will be clear and you could stop the medication. The thing is to remember here, reducing the eye drops to 4 times a day or 3 times a day, or it's not useful, because you won't be achieving the therapeutic level. So either you continue 4 times a day until things are resolved, and then you stop it altogether. Scientifically, it doesn't make any sense to reduce it to 3 or 2 or 1 with the antibiotics. Now, the thing is it's different with the acanthamoeba. Sometimes you might need to use the medications for 4 to 6 months, because if you stop it early, then there's a chance of recurrence, but also there's a chance of a resistant strain developing because of this. As I said, if you have access to confocal microscopy every few weeks, once they show clinical response, do confocal microscopy. If there is resolution of the clinical symptoms and there is no evidence of cyst on confocal microscopy, and you've spent like 3 or 4 months treating the patient, just stop the medication. It's a reassurance to stop the medication.
Another question, do you have any experience in the insulin-prepared eye drops for persistent corneal ulcer after infection? What do you think?
No, I've never used that. I've seen it in the literature, but it's very difficult here to try these things unless it's approved by the Royal College or by the hospital the pharmaceutical department or pharmacy department. Yeah.
How
So no,
about,
I don't.
yeah, thank you. How about using betadine 5% as drops? No.
No.
Yeah, of course, because as you said, off-label is something
Yeah,
critical.
it is indeed. And
Yeah. What about the infectious keratitis after PRK? Any special precautions or any special protocols of treatment because it is after PRK, or we can deal with it as any infection?
no, you could deal with it as any infection. As I said, after LASIK has been shown, some atypical mycobacterium, but normally they respond to the sort of antibiotics that we use normally.
Mhm. Um, Even with gram-negative bacterial infection, we can start corticosteroid 48 hours after the beginning of antibiotics? A question.
Sure, sure. Once you get a clinical response, yeah, it's actually you need them more in gram-negative like Pseudomonas because it's very severe. You could end up with really extreme severe inflammation that render the corneas, hazy, and you end up with a big scar tissue. So if you use it, and as I shown in the SCUT trial too, they trying to use the antibiotic within steroid within 24 hours of the so at the same time as the antibiotic. Yeah.
Will this presentation be available on YouTube? Yes, within maybe after 1 hour, it will be uploaded to the Sinjab Academy YouTube channel, inshallah, to the cornea series. Um, if you want to use the steroids, how frequently?
This is also a good question. You don't start with high dose. In fact, so what happened is you got a patient with infectious keratitis, corneal ulcer. You start the patient on antibiotic, then you see them in 2 days or 3 days. It depends on how severe it is, the infection. Then you decide to start the steroid. Now while the patient on a steroid, you keep the patient on antibiotic. However, you have to start them with the smallest dose because that's the only way they need initially. And then, so it goes, in sort of an inverse relationship. So as your antibiotic is coming down in frequency and you are sure that with once a day steroid or twice a day, you don't get corneal melt or any sort of adverse reaction, then you increase your steroid. So you start with once a day. It's more than enough, and then increase it accordingly. Because in some people and some patients, especially with big ulcers, you might need the steroid for a few months, even after stopping the antibiotics. Once you clear the infection and only scar there and the eye is white, just use once a day steroid, and you will see that even with the severe sort of corneal scar, some of them you think that they might need some sort of corneal transplantation. After a few months, things will clear up and then we'll get very useful vision.
Understood. In practice, if there is epithelial defect, don't use corticosteroids. Start with epithelium is healed. Is it right? I think Khalid means that steroids, there is a thought that steroids prevent healing of epithelium. There is, I think it is misconcept.
Yes, absolutely. This is misconcept. So the only thing is, in these sort of conditions, if you give a patient a steroid, you have to make sure that you're going to see the patient. You cannot miss the patient. If you are in doubts, then either give them the weakest one, the minimum one, and just emphasize on them that I need to come. But if you are in doubt, then and the infection is not sort of big and it's not central, then don't give steroid. But yes, we give them even if there is a epithelial defect, as long as we monitor things.
Is it mandatory to postpone using the steroids after full epithelial healing? Again, no. No, actually, there is no correlation. Just you can start it after 48 hours, regardless of the epithelial healing, or as long as you are controlling the infiltrates. And am I right?
Absolutely, absolutely.
And by the way, there is a very old paper published by Harvinder Dua regarding the effect of a lot of medications on epithelial healing, migration, and so on. And it showed this paper is it is a gold paper. You have to find it. And actually, you can see that it does not affect epithelial healing. The steroids do not affect epithelial healing at all.
Absolutely. And it's the thing is, in these sort of infection, if you have something which halt or stop the healing, it's the fortified antibiotics. But you would expect that. And once you reduce the frequency, things will get better.
Okay, so great. Now, a question from my side. Some surgeons, refractive surgeons, they do not use the steroids from day one after PRK because they feel that the epithelium, now it is the cornea is without epithelium, so let us cover the cornea with antibiotics first, and maybe after 48 hours to start using the steroids. What do you think about this? Is
Well,
there any evidence behind this?
not really. This is probably just anecdotal thing. But I'll give you a similar example because we do cross-linking and we take the epithelium and we start them from day one with topical steroid. And in fact, steroid, if you give it in a proper dose, not in high dose, with antibiotic cover, it can help to reduce inflammation, which sometimes can affect the healing. So in fact, the steroid can help with regeneration.
Yeah.
So even if the epithelium, we take the whole epithelium off, if you start after cross-linking or PRK, if you start a minimum dose, in fact, there is beneficial effect for the steroid. As long as I said, you monitor the patient, keep them with antibiotic cover, and tell them when to come, give them the warning signs.
Yeah, that's amazing. And by the way, replacing the bandage contact lens with a new one after 24 hours will enhance healing of epithelium after surface ablation or even after corneal abrasions, because in the first 24 hours, there are a lot of inflammatory mediators circulating on the surface, and the contact lens will absorb them and will keep them on the surface, which will delay the healing. So changing it after 24 hours with a new contact lens will enhance healing as well.
Absolutely.
Okay, so what about topical losartan after healing to reduce corneal opacity?
I've never heard of this.
Yeah.
Sorry.
Because nowadays it is mentioned in conferences, and it is prepared from the tablet of losartan. Yeah.
No, I have no experience in that.
Okay, super. Thank you very much, Dr. Mohammed. It was an amazing session, and I enjoyed and learned a lot from it. We hope to have more activities in the future, inshallah. Now,
Inshallah.
after we finish the glaucoma series, we finished the cornea series. Now, there will be something new, innovative, inshallah, starting next year. And Dr. Mohammed, I will be more than happy if you accept the invitation. I will tell you about this project later, inshallah.
Inshallah, it's always my pleasure. Thank you for the opportunity again. And thanks for the audience as well, for my colleagues for their feedback as well. Thank you very much.
Pleasure. Have a good night, everybody. Thank you.